about my humble opinion about what the optimal diet for human beings is, and it is one that is very, very low in carbohydrates. You don't disagree, do you, Paul? Of course.
I'm a fan of low-carb diets. And I mean, but the corollary of a low-carb diet is it's a high-fat diet. And we have a bunch of people scared about cholesterol.
Yep. I'm not one of those.
Thank God for that. I mean, so here's the thing, because you know what the association between high cholesterol levels and dying from infection is?
I wouldn't know that one particularly.
Way down. So we know in one study, they looked at a group of men. If your cholesterol was under 70, your LDL cholesterol was under 70 versus over 70, your risk of dying from sepsis related to the pneumonia was increased in the low cholesterol group by 5 times. We know all-cause mortality. We know that, you know, if we have a look at the balance of data, big meta-analysis looking at 19 studies, 16 of those studies found an inverse relationship. You know, it doesn't matter whichever way we look at it. When we have a look at total cholesterol, we have a look at LDL, we have a look at HDL, there appears to be an inverse relationship between all-cause mortality and mortality from infectious causes in all of those. So right about now, if you were truly worried about dying from an infectious disease, now's not the time to be lowering your cholesterol. No. Now's the time to be going on a diet that might actually increase it.
And especially not with a drug which is a metabolic toxin, a mitochondrial toxin that will lower your redox potential and thus lower the ability for you to undertake respiratory burst and thus protect yourself from pathogens.
Not many people know about the origin of the statin medication, the HMG-CoA reductase inhibitors. So I don't know if you're familiar with the original research.
Quite, yeah. But please, Paul, go.
Yeah, I mean, well, it was being, the Japanese scientists were the first to discover the statin medications. And they ended up in a bit of a quasi-war, a battle, a race with the American scientists. And the Japanese are actually progressing very well. And then they pulled out of the race. The reason they pulled out of the race, too many of their lab animals were dying. So they were dying from cancer, dying from other causes. And they just decided this is not safe. And probably the truth is that they were probably dealing with very potent statins that did what they were meant to do very, very well. They really blocked this HMG-CoA reductase. So the only way that the Americans were able to get FDA approval was by bypassing the normal channels. They had approval in record time with, you know, incredibly little oversight and no real scrutiny of the side effects that they were causing. But then, interestingly, I think it was Bayer, they came out in the 90s with what they called a super statin. And that was, they wanted a piece of this statin pie. You know, these are billion-dollar drugs. So they put out this super statin that was more potent at lowering people's LDL level than ever. And you don't hear about this super statin anymore. You know why?
Because it killed people.
Killed too many people. Yeah. Exactly. And you know what? They've actually, should be in the public domain. They actually had to pay out, I believe, in the order of over $100 million or more in compensation. So people knew that this drug was dangerous. And the only difference between this drug and the drugs that we have on the market is one of potency. So basically it was so much more effective. So one would wonder if you took a current statin in a high enough dose, would that render it as equally effective as this super statin was? Potentially, yes.
I think it would kill you at high enough level.
If you inhibit HMG-CoA reductase enough, it is essential for life. We do know that. The Japanese scientists figured that out. They've got a lot of dead dogs on their doorsteps that will tell you that.
Yeah. Interesting, isn't it? So from there, Paul, time does march on. So let's move on if you don't mind. As soon as I've got you, it's obligatory. It's Dr. Paul Mason. We have to talk about fibre for a few minutes. We all know the story on this channel because I've drummed it into my people from day one, and that is that, to my knowledge, there is one and only one controlled clinical study regarding fibre at all. Is that still correct, Paul? Or?
Well, look, there are lots of studies, but the outcome measures that they look at, it doesn't reflect what I consider the symptoms of constipation. So if I'm as a doctor, if I have somebody come in to me, I'll say, with a gastrointestinal upset, they'll say, look, I have pain, I have bloating, I have bleeding. They don't say, my stool isn't big enough. Literally, nobody has ever said that to me. They don't say, my transit time is too slow. Nobody even knows what their transit time is anyway. And yet, the studies that have actually been purported to prove the benefits of fibre will usually look at stool bulk, and they say, fibre makes your stool bigger, fantastic. Or they'll show transit time. Why? Because we know that fibre, because it's insoluble, does make your poop bigger. But let's be honest, making something bigger doesn't make it any easier to pass through a small hole. So, I don't understand how that logically makes sense. And while it might speed transit time through an iterative function, that doesn't necessarily help either. I mean, that nobody's ever complained about transit time. So if we have a look at the symptoms, the only one study that I could come across, I was writing a textbook chapter, a medical textbook, and I was up to the fibre section, and I was going through the science in every topic, and then I came to fibre, and I had a hell of a lot of trouble finding the original references. I could go guideline after guideline after guideline. So this original guideline would cite another guideline. It would cite an opinion piece. There was no original data. There was no experimental data saying what they said it was. And I finally came across this study where they had 63 people, and they were, it wasn't a true randomized control trial, but it was an experimental design. And they had idiopathic constipation. Idiopathic being a term we use, your doctor's an idiot and probably pathetic as well. Idiopathic in the technical sense means we don't know what causes it. So for most people with constipation, it is idiopathic constipation. That's just a term saying garden variety constipation. They're on a relatively high fibre diet, but then they put some of them on an even higher fibre diet, and their symptoms got worse. These 5 symptoms of constipation, like bleeding and bloating and pain, so on and so forth, they all got worse. Then they had some people on a medium fibre diet, got a little bit better, low fibre diet, got a little bit better. And then they had an elimination diet, 0 fibre, 41 participants. And every single one of these participants who had symptoms of constipation had complete resolution in every single metric of their symptoms, these 5 domains. Every single one. And the average rate of bowel motions was 1 bowel motion per day, every day. The high fibre group had 1 bowel motion from memory every 6.83 days. So no comparison, absolutely no comparison. Basically 1 poop a week on a high fibre diet. And these were obviously people who had struggled with constipation for a long period of time. And then people say, oh, but you need fibre because it produces short-chain fatty acids. Well, yes, it does. So what actually happens is that you'll have bacterial fermentation of the fibre because your body can't absorb it because it's basically a waste product, right? It's like eating wood. So these bacteria will ferment it. They'll produce gas, which is why you feel bloated. And then they'll produce short-chain fatty acids, which can get absorbed into some of the cells lining the intestines. And then the cells lining the intestines will convert that into ketones. And then they'll use the ketone as a source of energy, and that will make that cell healthier and stronger, better at producing mucus to protect itself, so on and so forth. But the problem is, this bacterial fermentation only occurs in a very focal part of the whole intestine. So there's only a very, very small number of these cells that will benefit. Far better for you to be in systemic ketosis and have ketones circulating around your whole system and being able to provide you with that thrust, with that energy and that entire gastrointestinal tract protection. So this whole short-chain fatty acid argument doesn't stack up either. And then we have these talks about, oh, you have to feed the microbiome. Bollocks. I mean, the microbiome is the biggest case of misunderstanding of correlation and causation I've seen in recent times. So we all know that, oh, just because the sun comes up, doesn't mean that this happens. The sun coming up doesn't make your alarm go off, even though they tend to happen at the same time. That's just, They're correlated. One doesn't cause the other. So when we have a look at the data, so we take a population of epileptics who are on a ketogenic diet, and we look at their microbiome. They have a phyla, the Bacteroidetes phyla predominance, and this is associated with good health. And yet, we don't say that this Bacteroidetes phyla gave these epileptics better control against their epilepsy. We say because they fed their bacteria different things, they fed a ketogenic diet, it was actually the ketogenic diet that protected them from epilepsy relatively. And the ketogenic diet just happened to change their microbiome, because we know we can get wholesale changes in the microbiome in a matter of 24 hours. If you feed it certain foods, certain bacteria that like those foods will outcompete some of the other ones, and they'll suppress the other ones. So 24 hours, big change in your microbiome. So correlation, causation. And we know this. Let's take the example of trehalose, which is a sugar, a disaccharide. It's synthetically synthesized. The Japanese discovered how to do it on an mass industrial scale in the early 2000s. And it's fantastic because it lowers the freezing point of foods. So it's really good for industrial food manufacturers to put in things like ice cream. So I think it was about 2002, 2003 in Australia, this got introduced into our food supply. Now, there's a bacteria in our gut called Clostridium difficile, which causes a dangerous condition called pseudomembranous colitis, where we get absolute massive inflammation and bloating, and it's incredibly dangerous. It does kill people. And this bug that causes it, Clostridium difficile, has an affinity to ferment this sugar, trehalose. So we noticed this epidemic of pseudomembranous colitis starting at this point in time when this got introduced into our food supply. And other countries around the world have also noticed the same thing. When they've had the introduction of this into the food supply, they have epidemics of this condition. And this is not just sort of some, bespoke theory that I've come up with. I've taken this from Nature. This is well published. There's a couple of articles in Nature Journal on this. This is solid science. So what you feed your bacteria what you eat will determine which bacteria are proliferate. And for the most part, there might be some small around the edges effects, but what you eat in the first place is a much more important impact on your health than what the bacteria subsequently do. And we know that if you feed people lots of probiotics, that often causes gastrointestinal upset. And if you eat a bacteria through a probiotic that you then subsequently do not feed, it will basically die off. So you'll need to be continuously having that same probiotic if you actually want to maintain that population, or you can just change your diet to feed a healthy bacterial population. The only way probiotics work, say if we want to stop you getting a bad strain of E. coli for causing traveller's diarrhea or something like that, is if you continuously ingest that probiotic in high doses. Then it leads to a relative degree of competition, where it can hopefully stop that pathogenic E. coli from getting a foothold in your microbiota. But as soon as you stop taking it, it's gone from your system. And there's a very good paper in India. There's a condition called necrotizing enterocolitis, which is often preterm infants often suffer from it. It's quite dangerous. And they have an overgrowth of very bad bacteria in their gut. And they found that they gave them a probiotic that would actually help compete against this infection, and it did nothing because they didn't nourish that bacteria. So then they coined the term symbiotic, synergy, where they actually gave it a source of food at the same time as giving the probiotic. They basically attached them together, and that proved to be very, very effective. So it really just goes to show that what happens in our gut is more of a reflection of what we eat, and what we eat impacts our health, at the same time impacting our microbiome. And I really think a lot of the stuff coming out about the microbiome at the moment is nothing but junk science.
Yeah, agreed, absolutely. I think that there is some stuff whereby, there are people, including myself, that often say we know more about the surface of Mars than we do about the microbiome in real terms. And I'm sticking to that until I'm proven wrong on it, which will happen at some point when the knowledge develops on it. But certainly we are clear that there are certain things that are associated quite often with patients who present with inflammation. So we know there are certain diets that are pro-inflammatory at large and certain diets that at large are anti-inflammatory.
Yeah.
We know that inflammation is at the root cause of insulin resistance. We know that insulin resistance is the underpinning of type 2 diabetes, obesity, many cancers, many dementias, many comorbidities of the exact population of people who are smack in the sites for this SARS-CoV-2 virus. And we know that we can ameliorate fairly quickly in terms of someone's metabolic function just by altering their diet. And what we're finding is the most effective method, as far as we can tell, is to remove pretty much all the carbohydrates and fiber and oils. Yeah,
exactly. I mean, what I've talked about so far, I mentioned the Bacteroidetes phyla being a good one. Well, the one that is not a good one is Firmicutes. And this one feeds on processed carbs. If you have an unhealthy diet, you are going to get this population thriving in your microbiota. That doesn't mean the Firmicutes is doing the damage to you, though. It's the crap diet that's doing it. The Firmicutes is just coming along for the ride.
Exactly. And it's therefore implicated as being a bad guy in the same way that cholesterol is implicated in heart disease, which is fundamentally ridiculous from the ground up. Analogy, firemen at forest fires. They didn't cause the fire, but you'll always find them there. They're not the cause. Cause and effect, again, isn't it, Paul Mason? It's the same thing. It's these people who want to run around and pretend to be knowledgeable, touting associations as causal artifacts. When does it end, do you think?
Look, well, here's the problem. We've had the wool pulled over our eyes for so long now. I mean, my very medical education was an exercise in misinformation for a lot of it, certainly as far as nutrition went. So, and this goes back a bloody long way. We go back to the famous Sydney Diet Heart Study, which was done in the late 60s, early 70s in Australia. And, this was done on men who actually had a history of coronary disease between 66 and 73. So basically they got men who had had heart attacks and they said, okay, you have your normal diet rich in saturated fat and you have your diet rich in polyunsaturated fats. Well, the results weren't ever fully published. They just weren't published. It was finished. The data collection, all that was done in 1973. And the true results were only published in 2013, some 40 years later.
Wow.
Why? I mean, God knows why. And how did they actually get published? Well, some guy, a guy called Chris Ramsden, actually discovered them on 9-track magnetic tapes in somebody's basement and basically, had to get permission to publish them and interpret them and, had to get IT help to, basically go back to this 40-year-old technology. And what did they find? Well, they found that those guys who were in the polyunsaturated group were 62% more likely to die. Say that again, 62% more likely to die if you have the oils and fats that are recommended by our dietary guidelines. And then we had this, what's called the Minnesota Coronary Survey that was run between 1968 and 1973. This was over 9,000 men and women in institutions. So they knew exactly what they ate. They knew exactly what they were doing, and records were meticulous. So 9,000 of these guys, it was double-blinded. And they basically looked at a high saturated fat diet and a high polyunsaturated fat diet. And the data collection finished in 1973. And then it took 16 years to publish the data. So why? Why the delay? Well, when the lead investigator was still alive, they asked him and he said, well, it's because our results were disappointing. We didn't get the results we wanted. We had a hypothesis we wanted to support, clearly didn't support the hypothesis, so we thought would fudge it. And it would be interesting to you to note that one of the co-investigators on this study, Ansel Keys.
Yeah.
Although his name wasn't on the paper when it was published. And even when they published it 16 years late, they still left off a lot of vital information. And that information only was again published in 2016. And what did this data that they didn't report on initially find, over 40 years later? Well, when you replace saturated fat with vegetable oil, your cholesterol does go down, correct? but you also are much more likely to die. So again, the same finding. So when you're saying where does it end, this whole correlation causation, I don't know that it's people genuinely misunderstanding correlation causation, or are they deliberately trying to deceive us because they've got a preconceived notion, they've got a personal agenda that they're trying to hide. And we move to the modern era, the Women's Health Initiative study that was published in 2006. So it was over 48,000 females who were either in a low-fat diet or not a low-fat diet. So for $700,000, you buy yourself a bloody good study. You don't leave anything to chance. You have big numbers, properly randomized, properly supervised, and then you would assume that when it comes to writing up the manuscript, that would be incredibly well edited. You would have, editors coming out. So the funny thing is, I don't think they got very good value for money because there was only one statistically significant finding in this whole goddamn trial, and they forgot to put it in the results table. Awesome. They forgot to mention it in the conclusion. They forgot to mention it in any of the press releases. They forgot to mention it in any of the multiple media interviews. I think they actually, they were ripped off as far as their editorial support. $700 million doesn't get you a lot these days. But what that finding was that if you're a female, there's a Women's Health Initiative, and you had a history of heart disease and you went on a low-fat diet, you were 26% more likely to suffer side effects like heart attacks. Read, low-fat diet, 26% more likely to have a heart attack. That was the only statistically significant finding from the whole study. So that finding should have been shouted from the rooftops. And essentially it was buried. You could only find this out in page 661 of the journal, buried in obscure text with no elaboration at all. And it's quite immune to any penetration by anybody but the most inquiring minds who say, hang on, what does this incredibly obscure sentence mean? So from memory, it was something along the lines of the HR for those in the low-fat group was 1.26. And what does that even mean? So, have to say, well, HR is hazard ratio. We presume they're talking about, cardiovascular events being like heart attacks. And there's a degree of where you actually have to interpret that. And funnily enough, even though they said they didn't say it was the only statistically significant finding, but when you have a look at the confidence interval, it's very obvious that it was. Why was that dropped off the results table? Why was it dropped off the conclusion?
Because it wasn't in line with the ideology they were pushing.
I think there is a degree of deliberate deception. And I don't say that lightly. I've only recently started saying that. But when we have a look at this, there is a clear pattern of these investigators who are pushing a barrow, trying to provide their own agenda to support their own narrative, that narrative being the lipid heart hypothesis. And unfortunately, they're being incredibly disingenuous and they're deceiving the public by way of omission of information.
Yep.
And so when you say, where does it go? Where do these misunderstandings end? Well, I think it's when we call people out and we call academic dishonesty what it actually is.
Oh, thank goodness, my life has purpose. Oh, yay. I've repeatedly done just that on my channel, Paul. It's all about calling the charlatans out. So I'm really, really glad that that's all come out and that I'm not the only person saying it. So thank you for that.
Look, not all. I will make a point though, and maybe I'm getting a bit defensive because I'm a doctor. I don't think doctors by and large are evil people. But if you've been through medical school and you've studied for X number of years and you've had this stuff rammed down your throat, I think it's difficult to actually comprehend that what you got taught was actually not just wrong because it was, through quirks of research at the time, but through deliberate deception. That is very hard to take. And I don't think most doctors deliberately go out to give their patients bad advice. I know most doctors don't do this. Most doctors genuinely want to help their patients. So as silly as this sounds, I think doctors are victims as much as the general public in this whole era of misinformation.
Yeah. Absolutely agreed.